What's up, everybody? This is the Strength and Knowledge Podcast. I'm your host, Dr. Zach Baker of Rehab to Perform and R2P Academy. And today with us, we have special guest, Dr. Abbey Hammann, one of our 2 sports residents here at Rehab to Perform. And Abbey is wrapping up her residency. Just like Seth, we are coming down the home stretch. So this will be one of the final 3 research article reviews she still has left to do. And we are in the month of concussions here at R2P within our classroom and didactic portion of the residency. So that's what the research article is on. And Abbey, do you mind letting the listeners know what was the title of the article that you chose and why did you choose it?
So the article we're going to go through today is titled "The Use of an Intensive Physical Exertion Test as a Final Return to Play Measure in Concussed Athletes." This is a prospective cohort, and essentially it's just reviewing and testing the efficacy of the Chicago Blackhawks test. That test, for those of you that do not know, has 2 components. The first one is going to be incorporating kind of some cardio stuff such as stationary cycling, hill climbs, and higher intensity activities, whereas the second component is going to involve things like lateral hurdle jumps, lateral box jumps, and then jumping in 180-degree turns and burpees. With this test, similar to a lot of the other concussion tests that are out there, you're assessing and looking for signs and symptoms and subjectively taking reports of patients having symptoms throughout each of these steps. The Blackhawks test has a very nice chart that takes you through all the testing. And I was talking to Dr. Paula McCorkle the other day, and she said that she's even had students take individuals through this test before. And it's a very fail-safe test to kind of take people through.
And for those that are unaware, concussion rehab, one, it is a thing. We do rehab for concussions. And there's a variety of things that can influence concussion symptoms, physical exertion being one of them. But you can have people that have visual disturbances, and just having them doing different visual tracking and eye-related movements can flare them up. You can have things that are more vestibular or positional in nature. So whether you're sitting or standing or lying on the ground or inverted, lying on your back or your stomach, those different positions and how quickly you come in and out of those positions can give people issues. And then also just general physical exertion. And as you increase exercise intensity, going from a walk to a jog to a sprint, using body weight as resistance to increased external load, those are all different things that can flare people up as well. So a lot of your rehab-based protocols are increasing exertional demands in a very graded manner and monitoring response. What I really like about this Blackhawk test compared to some of your other traditional tests like the treadmill protocols is the Blackhawk test, it not only looks at changes in exertion level, but it also looks at impact and going from stationary activity to things that have impact. They talked about doing burpees and some other activities where you're jumping and rotating. Those involve changes in positional demands as well. And with all of that, you're going to have some different vestibulo-ocular demands as well. So I like this test because there's a variety of ways that you could potentially flare somebody up that you need to attempt in the clinic in a structured environment before you put them out in a competitive field. So, Abbey, do you mind talking a little bit about the study design, who was involved, what were the interventions that were done, just kind of, we know what the study aimed to do, but how was it actually performed?
Yeah, so big thing with the study is that all the research out there attributes the physiological timeline for recovery. It's now known to be outlasting symptom recovery. So an individual may not have symptoms as they're going through some of these testings. So like you mentioned, the VOMs, all that oculomotor stuff, they might not have any issues doing any of those more lower level testing. But when it comes to the demands of their sport, that's causing a little bit more symptom reproduction. And we can't accurately assess that without having them be exposed to those demands. So with this prospective cohort study, the cohort were ages 12 to 25, 40% of those individuals were female, and these individuals had to have a concussion due to sport, and it was treated at the CCMI clinics in Canada. With this, there are 87 clinics in this organization. All of the individuals that administered this testing had some sort of specialization or previous history of working with concussion-based individuals. The sports that they were commonly seeing with concussions in the study were number 1 were ice hockey, followed by American football, followed by soccer, and then rugby, and then basketball. All of this data was extracted from the database that they used collectively between the 87 clinics. And with this, the data was collected for about a year, so January 2016 to about February 2017. And with this, their protocol dictated that each stage of the protocol had to last at least 24 hours. So at most, you were going through 4 stages of return to learn, which is pretty common in concussion care, and then the 6 stages of return to play that follow the return to learn. So obviously we're not having individuals return to sport if they haven't yet been able to return to school and work activities without symptom reproduction. And then with this, during the 6th stage of return to play, the Buffalo concussion treadmill test was assessed following their full return to classroom without symptom reproduction. Once the individual passed the Buffalo concussion treadmill test, they were then exposed to the Blackhawks test, which is also known as the Gapsky-Goodman test, which I would say is more commonly known in the literature to be titled as.
Cool. And then with this, so they go through return to learn, they go through return to play, they go through the Buffalo test, then they kind of graduate to the Chicago test. What were they actually measuring with this, or what did they end up finding when they were taking people through these progressions?
So big things that they were looking for is the severity of symptoms that individuals were having, how many symptoms they were exposed to, whether it was just dizziness or they were also having nausea. You can talk about all the hallmark symptoms of a concussion that an individual can experience, but they were also assessing the return to play timeline. So from what I now understand after talking to Paula a lot is that the return to play timeline should be no less than 22 days to allow for adequate recovery, even if the individual is asymptomatic all the way up until the 22 days. Additionally, they were looking at the days to the first Blackhawks testing attempt. With this testing, the second an individual is symptomatic with the Blackhawks test, you are ending the test because they did not pass. And then you give them some time to kind of work through things, continue with the rehab, and then you'll test them again. Now, the testing standards of when you do the second test isn't kind of well known yet because there's a lot more research coming out on this. And I think concussion is still a fairly new and novel topic to the PT world in a sense of recovery and being the most appropriate and efficient we can with concussion management.
And that is interesting because you look at some protocols where you can return as quickly as 7 days. And I think there's a lot of things that factor into this. But I think one thing that is important to highlight is the difference between being symptom-free and being ready to play. And that doesn't necessarily mean being ready to play also has to take into account if you are absent from competition, there are things beyond the concussion that you need to address as well. General deconditioning and just physical and really psychological, mental readiness and preparedness. And this is no different than the individual that is 6 months post-op ACL. They have good range of motion. They have good strength. They don't have any pain with activity. But there's a lot of things that they have not done or they have not trialed at a competitive level that would warrant putting them on a field of play. And just because, yes, they can run in isolation, they can do agility drills in isolation, they can do different neurocognitive dual tasking drills in isolation, they haven't done all of that together. They haven't done it at the frequency, volume, or intensity that's required. And maybe they haven't done it in a structured competitive environment such as a practice or something that is a game-like situation. So when I hear the difference between symptom readiness and overall preparedness to go back, that's kind of where my head goes in the ACL space.
Yeah, and I think that's also the hard part about research and concussion management is the fact that it's not like you're going to give someone a concussion and go about like doing a randomized control trial. So a lot of the research out there is either like a prospective study or just an analysis of some of those other prospective studies. So I think that's a really hard part with concussion management and why the research isn't as quickly coming out as some other things like ACL per se.
Now, what did they actually find with some of the results of this study?
So one thing that I loved about this study is that they looked at an individual's pre-levels of anxiety. So do they previously have any existing conditions in regards to depression or anxiety. And about 6% of the individuals in the study reported significant bouts of either depression or anxiety. And this is a known factor to contribute to someone being more predisposed to be suffering from a concussion. With these individuals, about half of them had reports of prior concussion. 31% reported having one previous concussion, 14% reported having two previous concussions, and then 37% reported having 3 prior concussions. So I feel like that's a pretty decent bout of people within the study that have had a previous history of concussion. With everyone that was tested, there were 759 people that went through all of this testing. 85% of them passed on their first attempt, and 14.6 failed to return to play because they had symptoms throughout the Chicago Blackhawks test. With that being said, all of these people that went through the Buffalo concussion treadmill test, they all passed at 100%. And so typically, previously, a lot of those individuals would be returning to sport, but then you look at this number that at least 14% had symptoms. I feel like that's a pretty significant number in regards to kind of what they were looking at as far as efficacy goes for this trial.
No, that is, it's interesting when you look at the amount of time that we continue to acquire data and information on different injuries, and we start to realize, maybe there's a better way of doing things, maybe not necessarily better, but a more detailed and more in-depth way of doing things. And I think a big take-home message for this is that it's not that necessarily the Buffalo treadmill test is inappropriate, it's just not the end game. It's not the end-all, be-all with regards to giving you an all-encompassing profile of what an individual's abilities are. And it is a piece of the process, but it just gives them permission and the availability to move on to the next phase of what this process entails. 15% of the people who were able to pass that were not able to pass this. And when we think about the significance of a concussion, 15% of people going out and back onto the field where they have potential for potentially second impact syndrome or a additional concussion, the stakes are a little bit higher with that compared to an ankle sprain or compared to patellar tendinopathy or something that's a little bit more benign in regards to what is the most catastrophic event that could happen from somebody potentially returning earlier than what they were medically ready to do. Going through this study, and Abby, if there were any other results or stats that you thought were interesting, feel free to put them out. But what was kind of the bottom line or the conclusion that you ended up drawing from this?
So I thought another significant relationship with this was that the individual's mean initial symptom severity scores between those who passed and those who failed on their first attempt was pretty significant. So that's kind of an interesting thing to see, like up front, this individual may have a higher symptom severity score. That means I might assume that this could be someone that may pass or fail despite them being successful in return to learn, return to play, and the Buffalo test as well. Big things with this is that the Buffalo concussion test, like you said, I think it's a very important part to include in concussion recovery in a sense that kind of having a graded return. So can I do the return to learn? Can I do part of the return to play? Can I implement the linear exertional testing with the Buffalo concussion testing? And then can I add on the added effect of the Blackhawks test with testing more vestibular and oculomotor stuff with more anaerobic and dynamic demands, making things more multiplanar, especially for individuals that are more high risk and their sport involves them cutting, jumping, running, all of that. And then also the addition of like activities that are relevant in more contact sports. And then the last thing that I kind of thought was interesting and is I think important for like clinical practice is that clearance to return to play post concussion is definitely dependent on state mandated guidelines. It was not known to me that in Maryland, PTs, you can't return anyone to play for concussion. But I think that means that we become more of an important part in the testing mechanics of everything in regards to can we make sure this individual is safe to return to play despite us being the one that signs the dotted line that officially lets them go back.
And that's a conversation that I've had with individuals where they come in, maybe they're a direct access patient, or they come in asking for clearance for return to play. And what I end up telling them is, I can take you through progressive testing. I can do an evaluation. I can let you know what you are doing well, what things you are still struggling with, and just give you a very definitive and objective status as to where you are currently. That information then goes to the available parties that it needs to, whether it's the school's athletic trainer, whether it is the primary care physician, the neurologist, whoever is overseeing the plan of care that within our respective state is the ultimate person who's going to sign off. So we are more of like the information gatherers, and we educate the individual on where they are at from a functional standpoint, that somebody else can then take that information and then deem their readiness and their appropriateness to return. And when I look at the Blackhawks test, what it reminds me of is just really good progressive exercise prescription. And I think, and correct me if I'm wrong, this test has not been formally validated yet. Is that correct?
Yeah, not yet. No.
Yeah, so I do think that's important. But the themes within the test, it's no different than just really good exercise prescription. And if somebody can go through a Buffalo treadmill test, that tells you as a clinician, hey, I know that I can ramp up this person's heart rate. I know I can ramp up this person's respiratory rate and their blood pressure a little bit, and they're not going to have a symptom or an episode that they previously had with a concussion. So now I can get them off the treadmill. I can get them into open space. We can start doing progressive strength training at higher intensities in the gym. We can not only run and ambulate in a straight line at higher intensities, we can start doing multiplanar tasks. When we can start doing multiplanar, multidirectional tasks, now we can add in other elements. Maybe it's reactive components, maybe it's visual stimuli, maybe it's other sport-specific elements that we have to do, decision-making on the fly, and a lot of this really just looks like really good return to play and return to sport exercise. But what the Chicago Blackhawks test does is it gives you a template to go off of with that. So I'm glad to see that there have been advancements just in a structure to follow. Ideally, over the next several years, we get more data in regards to what does this look like in regards to standardization and overall utilization and how we implement it within the return to play process. But for those who are unfamiliar or just uncomfortable with what a good exercise progression looks like or a good testing format looks like, familiarize yourself with your basic orthopedic and just general medical screening procedures regarding concussion. Familiarize yourself with the Buffalo treadmill test. Familiarize yourself with the Blackhawk test. Practice it. Practice it on yourself. Practice it with other students or colleagues that you have, and then begin implementing with patients as appropriate. Abby, anything else from this article that is of interest to you or that we did not hit, or do you think we got it all?
I think we hit all the big points. The article is pretty easily accessible if you have any research stuff, and I think it's a cool one to check out because it also includes the test on there and has some tidbits about advice as far as administering it as well.
Awesome. Well, Abby, thank you as always for doing the dirty work and going through the literature, filtering it out, and getting it to us in a more palatable format. For those who are listening, this is the Strength and Knowledge Podcast. I'm your host, Dr. Zach Baker. If you've enjoyed this episode, please like, share, and subscribe, and stay tuned for our next episode.